on time.
اوكي. دي المحاضرة عن arrhythmia for medical students. Conductive system of the heart consists of the sinoatrial node in the right atrium between superior vena cava and inferior vena cava. 3 fibers transmit the impulse initiated from the sinus node to the AV node, and from the AV node, bundle passes at the upper limit of the interventricular septum, the muscular part, divides into right bundle and left bundle, and then Purkinje fibers to transmit the impulse to the muscle of the right and left ventricles in the same time. There is a fiber from the right atrium to the left atrium also to transmit impulse from the right atrium to the left atrium. The conduction of the impulse in the conductive system is much faster than conduction through the muscle. Again, the conductive system of the heart, the AV node, some fibers in the AV node transmit the impulse faster. It's called fast pathway. And the fibers transmit it slower. It's called slow pathway. This is called dual physiology. Why I tell this to 5th year, it is sophisticated. Why it is should be over graduate students. But you have to know that sometimes in girls or boys, the fibers in the AV node that have dual physiology, the impulse may pass in the fast pathway and return in the slow pathway, and then return again in the fast and cause circus movement, re-entry, tachyarrhythmia. So this is the mechanism. Again, the conductive system, the SA node in the right atrium, 3 fibers pass the impulse to the AV node, then right bundle and left bundle, and the Purkinje fibers. The depolarization of the atrium causes P wave, depolarization of the ventricle causes QRS, repolarization of the ventricle draw the T wave. The T wave is the repolarization of the ventricle. This is the normal ECG. The lead 1, 2, 3, AVR, AVL, AVF, and 6 chest leads. So the number of the leads is 12. The normal P wave is upright, QRS is upright, T wave is upright in lead 1 and lead 2. It is only inverted in AVR. If you find the impulse is upright in AVR, it means that the nurse put the electrodes incorrectly. The red and yellow change. Again, this is the normal electric wave of the heart. The impulse in the heart is 90 volt, 90 millivolt. The apparatus of the ECG magnify it 1,000 times and drew the impulse. The P wave, atrial depolarization, from the beginning of P to the beginning of the QRS is PR interval. PR is the time of conduction of the impulse in the SA node, in the atrium, in the AV node, in the Purkinje fiber, in the bundle branches. So it is a long journey. QRS is ventricular repolarization. From the end of the S to the beginning of the T is ST segment. This is important segment. It is usually isoelectric in the same line of this line. If it is elevated or depressed, it means injury. From the beginning of Q to the end of the T is called the QT interval, and this is important. So this is the QRS and the electric impulse of the heart. Arrhythmia is divided into rapid and slow. When it is above 100, it's called the tachyarrhythmia. Below 60 is called the bradyarrhythmia. And it is regular or irregular. Rapid regular causes are sinus tachycardia, supraventricular tachycardia, atrial flutter, ventricular tachycardia. Rapid and irregular, atrial fibrillation. Slow and regular, sinus bradycardia, nodal junctional rhythm, or complete heart block. Slow irregular is slow atrial fibrillation. Now we start with sinus tachycardia. The causes are physiologic, pharmacologic, pathologic. Physiologic, during infancy and the childhood, the heart rate is usually above 100. during exercise and during emotion and excitement, the heart rate increases. Pharmacologic, if you give sympathomimetic drug, Ventolin, epinephrine, it causes tachycardia. If you block the parasympatholytic it causes block of the vagal tone, so the sympathetic tone takes the upper hand and causes tachycardia. Also, thyroid hormone and the nicotine and the caffeine and the alcohol cause tachycardia, pharmacologic tachycardia. Pathologic causes of tachycardia: fever, hypotension, heart failure, pulmonary embolism, hyperkinetic circulation, anemia, hyperthyroidism. This is example of heart rate of 120 in a lady who is having bronchial asthma and takes Ventolin inhaler. It causes sinus tachycardia. Sinus bradycardia causes also are physiologic, pharmacologic, pathologic. Physiologic: athletes, old age, carotid compression during sleep, all these cause bradycardia. I used to have heart rate below 60, even if I am not so much athletic. And at old age like me, I have heart rate below 60. Pharmacologic: digoxin, beta blockers, verapamil, diltiazem. Pathologic: convalescence from infections, hypothyroidism, obstructive jaundice, increased intracranial tension, hypothermia. Myocardial infarction, inferior myocardial infarction specifically can cause sinus bradycardia. This example of a premature beat is called extrasystole. There is no difference between the word premature or extrasystole. The ventricular premature beat have three features. The QRS is opposite to the T. If the QRS is down, the T is upright. And the QRS is wide and bizarre shape. See the normal wave and the extrasystole, completely different shape. These are examples. Here is sinus bradycardia, heart rate 50. This is atrial premature beat. This is junctional premature beat. When it is one normal, one premature, one normal, one premature is called bigeminy. This is sinus tachycardia, and the lower strip, the P wave is inverted. It is junctional rhythm. The PR interval is short and the P is inverted. This is junctional rhythm, or previously called nodal rhythm. Now we come to subject of supraventricular tachyarrhythmia. If a lady gets heart rate, sudden rise of heart rate, 170, 180, boom, 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 it appears suddenly and it disappears suddenly, it is called tachyarrhythmia. It may be paroxysmal or persistent or chronic. If it subsides in 2 days or 7 days by itself, it's called paroxysmal. If it subsides by interference by drugs or lasts more than 7 days, it's called persistent. If it lasts 1 year or more, it's called chronic or permanent. The mechanism of supraventricular tachyarrhythmia, I mentioned that there is fast pathway and slow pathway. Sometimes block occurs in one direction and the impulse passes here and returns retrograde. So the block is antegrade but not retrograde. Again, there is antegrade block but no retrograde block. So the impulse circles around the AV node. This is the block, the impulse. Again, the impulse returns. The block is antegrade but not retrograde, and the impulse circulates re-entry circus movement in the AV node and fires even up to 200, 210, 220. And the lady gets syncope, and then the arrhythmia subsides. And when she go to the doctor and finds that the heart is normal, he says to her, it is psychological. But no, it was attack of supraventricular tachyarrhythmia. This is example of supraventricular tachycardia. The P wave is not apparent. In fact, the P wave is hidden behind the QRS. You can find it at the end of the QRS. There is notch. The management of supraventricular tachycardia, you can do some maneuvers, carotid sinus massage. One of the professors used to ask the student how you can do the carotid sinus massage, and he is very strict. First you do on one side, it is beside the thyroid apex, and you massage the carotid 5 or 6 seconds, and then the other side till the arrhythmia stops. Or the patient tries Valsalva maneuver. He takes deep inspiration and then tries to blow while the mouth and nose are closed. This increases the intrathoracic pressure, and this increases the vagal tone and stops the arrhythmia. If these maneuvers does not succeed, we can give adenosine 6 milligram ampoule intravenous. If it does not succeed, give another 2 ampoules, so the total will be 18 milligram. If it does not succeed, give ampoule verapamil isoptine 5 milligram. It is very beautiful drug, and not expensive, and is found in every pharmacy. You can give it intravenous, and it will stop the arrhythmia. One of the causes of supraventricular tachycardia is called Wolff-Parkinson-White syndrome. This is congenital. Instead of the patient, the person is having 3 wires, 3 fibers passing the impulse from the SA node to the AV node. He has another extra fiber passing the impulse from the SA node to the ventricle direct without passing the AV node. It's called accessory pathway. And 3 doctors in the year 1050 discovered that some girls get tachyarrhythmia, and the ECG is having special morphology, short PR, delta wave, and wide QRS. And one patient died, and they dissected and found accessory pathway, and so it was called by their name, Wolff-Parkinson-White syndrome. White is called Dr. Paul Dudley White, and his resident, his assistant was Egyptian doctor called Tarazi. And I was fellow at the department of Dr. Tarazi, so I am student of the student of Paul Dudley White. Again, the Wolff-Parkinson-White syndrome is characterized by the presence of accessory pathway, and in the ECG you find short PR, delta wave, and wide QRS. This is very short PR. The P is attached near the QRS, and there is delta wave. Short PR, delta wave. The drugs given for accessory pathway for the Wolff-Parkinson-White syndrome, flecainide, propafenone, amiodarone, disopyramide. We have in Egypt propafenone and amiodarone. Propafenone trade name is amiodarone is called cordarone, and propafenone is called ritmonor. Also, you can give digoxin and verapamil. The final treatment is ablation. كي احنا بنشتغل مكوجيه بعد الظهر، بنكوي الاكسسوري باثوي، بندخل سلك في طرفه معدن، نوصله بالجهاز يولد حراره راديو فريكونسي يحرق السلك. خلصت انا السوبرا فنتريكولار تاكي اريزميا، نيجي للاترال فيبريليشن. Atrial fibrillation is common arrhythmia. It occurs more than 10% in old age. Above age 75, you can find 10% of persons having atrial fibrillation. It can be paroxysmal if it subsides in less than 2 days or 7 days by itself, or persistent if it subsides only by interference by the doctor, and permanent or chronic if it lasts 1 year. And the permanent or chronic is divided into 2 types. If the doctor decides that it can be corrected by drugs, it is called permanent chronic, and if the doctor decides that there is no hope, it will return to sinus rhythm and gives only rate control treatment, it's called permanent. This is example of atrial fibrillation. You, instead of the P wave, you find F waves. The number of the F waves is 400 to 600. The AV node cannot transmit 400 impulses, so it transmits 1 and leaves 2. So the impulse passing to the ventricle is about 150, 160. And the RR intervals are completely irregular. You see here, the RR intervals are irregular. So how to diagnose atrial fibrillation? You find instead of the P wave, F waves, and the RR intervals are completely irregular. Sometimes the F waves does not appear at all. It's called fine fibrillation. And sometimes it appears very coarse. It's called coarse fibrillation. The causes of atrial fibrillation are either organic heart disease as rheumatic, mitral valve disease, mitral stenosis or incompetence, ischemic heart disease, hypertension, cardiomyopathy, dilated or hypertrophic cardiomyopathy, atrial septal defect in 1/3 of cases of ASCD, constrictive pericarditis, myocarditis, 1/3 of cases get atrial fibrillation. Without structural heart disease, alcohol, thyrotoxicosis, obesity, smoking, pericarditis, pulmonary embolism, sick sinus syndrome. Any patient coming to the clinic with atrial fibrillation, definitely I do ask for TSH, thyroid stimulating hormone, to examine for any thyrotoxicosis. Even hypothyroidism can cause atrial fibrillation. Another example of atrial fibrillation, the last strip is continuous lead to. The RR intervals are completely irregular. And here there are F waves. Sometimes the atrial fibrillation occurs in accessory pathway in Wolff Parkinson. The impulse passes very rapidly from the SA node to the ventricle and transmits impulse 250. The AV node can never pass 250 impulses in 1 minute, but in the accessory pathway, there is no block. If the ventricle beats 250 per minute, it can go to ventricular fibrillation and sudden death. So more than once, I see a student with Wolff Parkinson and getting atrial fibrillation. In the hospital, they gave him cardioversion and reverted to sinus rhythm. When he comes to my clinic, I tell him, you have a very dangerous situation. You must immediately get ablation of the accessory pathway. First time it happened that you went to the hospital and they did cardioversion and succeeded to revert due to sinus rhythm. Another time, if it happens in home and you can have no time to go to the hospital, it can go to atrial fibrillation, into ventricular fibrillation and sudden death. This is emergency. Complications of atrial fibrillation are the following. Atrial thrombi. The blood in the atrium is stagnant. The atrium is having auricle. Getting out from the atrium is called auricle. بالعربي ودنا. أذين. This blood stagnant in the auricle can clot, thrombose, and the thrombus can be seen in the auricle. Sometimes it is detached, fragmented, and piece of it go. Usually it goes to the brain and causes hemiplegia. And more than once, a lady or a man did not know that he is having atrial fibrillation till he gets hemiplegia. Very sad. The impulse can go to the lower limbs and cause gangrene, can go to the kidney infarction, can go to the, I saw impulse went to the heart, caused myocardial infarction. Go to the retinal artery. A doctor in the morning found one eye cannot see. He went to the ophthalmologist. He said to him, immediately you do ECG and the echo. He came to me, I found atrial fibrillation and thrombi in the auricle. The management is anticoagulants. If the atrial fibrillation causes thrombi in the right atrium, it will go to the lung and cause pulmonary infarction. In the left side, it will go to systemic circulation. In the right atrium, it will go to pulmonary circulation. The second complication of atrial fibrillation is heart failure. Due to rapid irregular pulse, the ventricle is contracting 130 per minute and irregular. Day after day, if your heart beats rapidly, regularly, it can lead to heart failure. And the tachycardia can lead to something called tachycardia-induced cardiomyopathy. Another complication is the management. I give warfarin and the patient got hematemesis, hematuria, cerebral hemorrhage from the anticoagulants. And I say to the patient, you have to come to the clinic every 3 months to check for, he can pay the fee, pay the price of the ECG, pay the price of the echo, pay the price of the treatment of the drugs, pay the price of the complications, so complications of treatment. In the exam, every year, there is question, either mention the causes and management of atrial fibrillation or mention the complications of atrial fibrillation. Once or even more than once, a student wrote 2 lines, complications of atrial fibrillation, thromboembolic complication, heart failure. Do you want me to give you 10 from 10 in 2 lines? No. The university defines the answer must be not less than 15 lines. The question 10 marks, allowed, you are given 15 minutes. You must write in the 15 minutes at least 15 lines. So all the words that I said about the complications took more than 2 pages. Also the causes and complications and the management. You don't write very short answer. The patient may be liable to thromboembolism. There are risk factors for thromboembolism. It's called Shad-Vask. If he is having previous stroke, previous transient ischemic attack, or old age, more than 75 like me, you give 2 points. If he is having heart failure, hypertension, diabetes, age from 65 to 74, female sex, vascular disease, you give 1 point for each. If he gets 2 points or more, he is liable for thromboembolism. 1 point, no. The patient may be liable to bleeding. Shad-Vask score, this is again Shad-Vask score for thromboembolism. Heart failure 1 point, hypertension 1 point, age above 75 2 points, diabetes 1 point, previous stroke 2 points, vascular disease 1 point, age 65 to 74 1 point, 6 female 1 point. The maximum score is 9. If he gets 2 or more, he is liable to thromboembolism. The patient may be liable to bleeding. How to assess the bleeding? Has bled score. Hypertension gets 1 point, abnormal renal or liver function 1 point, stroke 1 point, bleeding, previous bleeding 1 point, labile INR once above 4, once below 2 takes 1 point, elderly 1 point, taking Voltaren or drugs or alcohol is 1 point. If the patient is having 2 or more, he is liable to bleeding. What is the benefit of, I know that the patient is liable to risk score to thrombolism or liable to bleeding. You adjust the dose accordingly. Management of atrial fibrillation. First, management of the etiology. If there is mitral stenosis, corrected, mitral regurg, corrected, heart failure, corrected, hyperthyroidism, corrected. So don't forget the word management of the etiology. You must give anticoagulants for any patient with atrial fibrillation. The guidelines say you give anticoagulants for atrial fibrillation if the patient is having 2 or more point score for thromboembolism. If he is having no score at all, don't give. If he gives just aspirin, if he is having 1 point, you can give or not according to the judgment of the doctor. I know patient with 1 point score did not get anticoagulants and he got thromboembolic complication and hemiplegia. So I never see a patient with atrial fibrillation, I must give anticoagulants. The more important than this, many patients reverted to sinus rhythm. I do not stop anticoagulants for life. Hemiplegia is catastrophic. The drug will not cause harm, but the hemiplegia is catastrophic, so I do not stop anticoagulants. The patient, you can decide to keep him on antiarrhythmic drugs for rate control or to rhythm control. The rhythm control drugs, amiodarone, propafenone, ritmonorm, or sotalol, betacor. The rate control drugs are digoxin, beta blockers, verapamil, diltiazem. More than once in the exam, I asked the student, what are the rhythm control drugs? He mixes. He says the digoxin, beta blocker, verapamil. And I asked him about the rate control. He says cordarone, betacor, ritmonorm. I forgive sometimes. So, but please remember, drugs for rhythm control are specific drugs anti-arrhythmic. Amiodarone, sotalol, betacor, propafenone, ritmonorm. Rate control, digoxin, beta blocker, verapamil. Anticoagulation is given for any patient with atrial fibrillation. When you receive a patient with atrial fibrillation, you have to do cardioversion. But you must be sure that there are no thrombi in the auricle. Otherwise, if the patient reverts to sinus rhythm, the atrium will contract and push the thrombus to the brain and cause hemiplegia. If the patient is coming in very short time, just the atrial fibrillation within hours or less than 2 days, you give heparin and cardiovert. If it is more than 2 days, you give anticoagulants for 3 weeks and then cardiovert. Or you do transesophageal echo to be sure that there are no auricular thrombi. In the exam, when I correct the paper, and the question is about treatment of atrial fibrillation, first thing I examine for the word transesophageal echo. If I do not find it, I remove mark from the 10. Transesophageal echo is a must before cardioversion. Or you can give anticoagulants for 3 weeks and be sure that the patient is taking it. The anticoagulants, the old anticoagulants is warfarin, Marivan, but it needs analysis every 2 weeks to check that the INR, international normalized ratio, is between 2 and 3. But there are new drugs called new oral anticoagulants, rivaroxaban, Xarelto, apixaban, Eliquis. I finished atrial fibrillation. It is the most important to study in the arrhythmia. You have to revise it by heart. You have to remember it as your name. Read it 5 times and close the book and memorize it. What are the causes? So. What are the management? So. What are the drugs for rate control? So. Rate control, rhythm control, complications. Now we come to another arrhythmia, atrial flutter. The atrium beats 300 or 360. The AV node cannot transmit 300 in 1 minute. It transmits 1 and there is a refractory period and then transmits the 3rd beat and so on. So it's 2 to 1. Here there are 2 P waves and the rate of the atrium is 300, the rate of the ventricle 150. If you ever find a patient in the bed with heart rate, ventricular rate 150, remember atrial flutter. The patient was given digoxin and verapamil and cordarone. The atrial flutter is very resistant to drugs. The AV node did not transmit all the impulses, so it became 4 to 1. This is 4 to 1 atrial flutter. 3 P waves are seen, and the 4th P wave is hidden behind the QRS. Very important to know that we can treat many arrhythmia by ablation. Supraventricular tachycardia is treated by ablation. Atrial flutter is treated by ablation. Ventricular tachycardia by ablation. Even ventricular premature beats by ablation. Atrial flutter, the most important treatment is ablation because drugs are not successful in many cases. So radiofrequency ablation, you can ablate for accessory pathway, AV node reentrant tachycardia, atrial flutter fibrillation, ventricular tachycardia, ventricular premature beats. We ablate by radiofrequency, but the new technique is by cooling, cryoablation. We have in Alexandria very famous, very up-to-date center, one of the best in Egypt about ablation. So if you receive a patient who is in need of ablation, don't transfer him to abroad, transfer him to our center. Another arrhythmia is called long QT syndrome. You imagine the QT from here to here is very long QT. It leads to arrhythmia, ventricular tachycardia is called torsade 1, and the ventricular fibrillation, and the patient dies. And this is one of the causes of sudden death. The normal QT is below 400 millisecond. If it is above 430, it is long QT. Another example of very long, very long QT from here to here. Here also long QT. Here also long QT. It is lethal disease. The long QT syndrome is managed by putting pacemaker in the heart, implantable cardioverter defibrillator. If the patient gets sudden death, the pacemaker reverts the defibrillates the ventricular fibrillation and initiates the impulse. I finished supraventricular tachyarrhythmia. We come to ventricular tachyarrhythmia. Ventricular tachycardia, there is nothing called physiologic. This is definitely pathologic. This is wide QRS, more than 140 millisecond, definitely ventricular tachycardia. Another example of ventricular tachycardia. Another example of ventricular tachycardia is horrible. It can lead to sudden death. Another example of non-sustained ventricular tachycardia. If the tachycardia persists more than 30 seconds, half a minute, it is called ventricular tachycardia. If it is less, it's called the non-sustained ventricular tachycardia. This is example of polymorphic ventricular tachycardia. Some of the beats are above the line, some of the beats below the line. This is called torsade 1. The patient is having very long QT. Imagine from here to here, very long QT. And this is lethal. The last slide in the lecture is ventricular fibrillation. Any patient dying before this, there is ventricular fibrillation in most of the cases. And the ventricular fibrillation can be secondary or primary. Secondary after severe myocardial infarction and heart failure, pulmonary edema. This is secondary. Primary, for example, in Wolff-Parkinson-White syndrome, Brugada syndrome, ventricular premature beat. When the heart stops and the patient dies, we call too good to die, too good heart to die. And the management of ventricular fibrillation is nothing but defibrillation. I have defibrillator in my clinic. One paper reported that if you give 2 ampoule cordarone intravenous to ventricular fibrillation, it can revert to sinus rhythm. This can happen in 17% of cases. This is another example of ventricular fibrillation. Heart block. Heart block is divided into first, second, third degree. Prolonged PR is first degree heart block. The normal is 200 millisecond. If it is above 200 millisecond, it is first degree block. Or the impulse passes and the conductive system of the AV node gets fatigued, passes the impulse after longer time, and then after longer time, and then blocked, completely fatigued, the impulse does not pass. So if there is a progressive prolongation of PR till there is failure of conduction, is called Winkbach. Again, the impulse here passed after longer time, and then failed to pass. The conductive system became completely fatigued, could not pass the impulse. The progressive prolongation of PR is called Winkbach block type 1, Mopitz type 1. Mopitz type 2 is sudden failure of conduction. Here there is complete disconnection, discontinuation between the atrium and ventricle. The atrium is working by itself alone, and the ventricle alone. They are divorced from each other. The ventricle is on focus in the ventricle regular on rate 40, and the atrium on rate 75. And there is no relation between the P wave and the QRS. Completely no relation whatsoever. The P wave is here, is above, after it. This is example of complete heart block. Another example of complete heart block in an infant. The P wave here The mechanism of studying ECG is to study the P wave alone, study the QRS alone, and then see who is married to whom, the relation between the P wave and the QRS. Is it 1-to-1, 2-to-1, completely disconnected, completely asynchronous, complete heart block? The treatment of complete heart block is pacemaker. We open subclavicular and get the subclavian vein, and then insert the catheter to the apex of the right ventricle, and then insert the pacemaker in a pocket and close. Can take 15 minutes if it is a smooth procedure. I finished the lecture. Again, it is on the YouTube and on my place, Dr. Samir Rafla lecture. Thank you. I will close the recording and then hear all your questions.